Good evening, all. My name is Dr. Arun Kumar K. I'm the mentor for MRCM OSCE sessions conducted by StudyMEDIC and conducting MRCEM SBA exams as well. So today evening, we are conducting a small session on stroke. So this is a part of a YouTube series which we do normally. So here I will be covering about the depths of the subject of stroke, which is entirely related to emergency department. All right. So my highlight of this presentation will be like what are the possible types of stroke, what are the clinical symptomatology. We will be covering certain pre-hospital maybe studies, which is including what is done in Cincinnati pre-hospital score and something called as ACT FAST. We will be covering certain subjects regarding what are the indications to thrombolysis and how to thrombolize, what is the drug of administration, the indications, the contraindications, as well as certain studies which is helping out with the thrombolysis administration also. And then finally we'll come to certain subjects which is including special presentations of stroke. Right. So starting with the etiology of the stroke, we mainly have three main etiologies. One is basically a large vessel atrial thromboembolism, which can be either intracranial or extracranial. Then we have small vessel disease, which could be like affecting like a lacunar infarct. And then we have a embolism, which is basically because of a cardiac emboli. And other causes which is including is mainly the carotid artery or the vertebral artery dissection or the hypercoagulable states or even special conditions like sickle cell disease and cervical artery dissection. Moving on to the ischemic stroke, the most important pathophysiology is there is basically a arterial occlusion which is leading on to abrupt cessation of the blood flow. So the brain tissue will receive absolutely no blood flow, which is what they call as the ischemic core, in which you will see the the brain cells rapidly die off. And according to the data which has been published, almost every minute 1.9 million neurons are being lost because of the stroke which has been untreated. So that signifies the amount of time which we cannot lose when a patient presents a stroke to the emergency department. Then there is something called as a concept of ischemic penumbra. So that comprises of the tissue which is hyperperfused, functionally impaired, and at risk of infarction. So at some cost, we will definitely have to save this ischemic penumbra, which needs to be reperfused. So what is this ischemic penumbra? So that contains electrically inexcitable but viable cells. The problem is more the duration of infarct, more cellular damage it will happen. So it's very important to act fast and save the penumbra. So as I told, the longer that the penumbral tissue remains untreated, the greater chance of them going for an infarction. Right, a quick note about the cerebral circulation, what we are dealing with, especially in strokes. So as we all know, there are major vessels in the brain. I would say we can put that as classification of 5 major vessels, which includes the middle cerebral artery, which contains, so the anterior circulation is mainly comprised of the middle cerebral artery and the anterior cerebral artery. And then we have the internal carotid artery, which supplies almost the anterior 3/5 of the cerebrum, which is predominantly the frontal lobe, the parietal lobe, and the part of the temporal lobe. Then we come to the posterior chain of arteries, which is mainly comprising of the vertebral arteries, which is supplying the posterior 2/5 of the cerebrum, the occipital lobe, part of the temporal lobe, and they supply the cerebellum as well and the brainstem also. So when you talk about anatomy, the basilar artery which is 2 in number, which forms a unit to form two vertebral arteries also, which gives off the posterior cerebral arteries. Then the most important artery is the common carotid artery, which is again divided into the external carotid and internal carotid. External carotid is something which is related to the brain, which is supplying the exterior of the head, the face, and the greater part of the neck. And then we can have the arch of aorta, which is the portion between the ascending and the descending aorta. And the left common carotid artery directly originates from the highest part of the arch of the aorta. So these are the blood vessels which are related to the cerebral circulation, which is very important for us to know regarding the topic stroke. So this slide tells us the importance of the cerebral arteries involved and the clinical features by which the patient may present with. So starting right from the anterior cerebral artery, which we can very well see the diagram. If you see the left side of the diagram, the anterior cerebral part or the artery is supplying mainly the hip, the knee joint, the ankle, the toes, and the torso, due to which the patient can present with weakness of the lower limb more than the upper limb. Okay. So when you see the middle cerebral artery, which is predominantly supplying the middle part of the cerebrum, so that is where the hands, the representation of the hands, fingers, thumbs, eyes, face, and lips is most predominant, due to which the patient can actually can have weakness of the face more than the arms, more than the legs. So face is more than the arms, which is more than the legs, the representation. The weakness. The patient can have aphasia, the patient can have hemisensory defect also, and the patient can actually have homonymous hemianopia as well, because there is involvement of the eyes as well. And coming down, the patient can have homonymous hemianopia and visual agnosia and prosopagnosia when the posterior cerebral artery is involved, which is supplying the occipital lobe and the almost cerebral part also. Okay, so this reflects the cerebral territory and the symptoms by which the patient can present with. And most importantly, the posterior cerebral artery involving strokes will have symptoms suggestive of bulbar palsy, because the jaws, the tongue, and the swallowing is involved. So it is very important to know which could be the possible culprit artery and what are the symptomatology the patient may present with. Now, the next slide is basically showing, now we have dealt with the arteries, we have dealt with the etiology, we have dealt with some of the symptoms which has already been discussed. Now we come to the clinical assessment, the risk stratification. So one of the very most important things is early recognition of stroke. So to aid that, a special tool has been advised, especially in the pre-hospital assessment of a possible stroke. There is something called as a tool called FAST, which is basically face, arm, speech, and test, or probably the time. Now, what is the importance of FAST? That means act fast. So this is something which has been introduced by the NHS, which actually studies have proven that the public awareness has grossly increased, because it is very easy to remember the mnemonic FAST, due to which the patient reporting in the hospital also has increased. So what normally they do is the public actually knows what is FAST, and they ring the EMS team, and they make sure such a patient who has developed signs and symptoms of stroke reaches the emergency department at the earliest, so that the treatment protocol can be given at the earliest, thereby preventing further deterioration of brain cell damage. So when you look at the FAST, you have face weakness, arm weakness, speech disturbance. Each symptomatology has a score of 1. Okay, and T refers to the time. So that means a minimum score of 1 has been given, And the time basically refers to the time of onset of all these symptoms. Okay. So as I told earlier, FAST has been used by the ambulance services, and it's a very important part of the paramedic training and documentation in the UK. And it has a positive predictive value of 78% and negative predictive value of 73% for paramedics to use to recognize stroke. And among the public, the FAST campaign has raised awareness of stroke warning signs, as of the awareness of facial weakness, the arm weakness, and speech problems. But one drawback which has been told is when it comes to posterior circulation stroke, symptomatology like leg weakness or visual loss, which has not been documented in the same mnemonic. So identification of strokes of either posterior cerebral artery or even anterior cerebral artery is being much lower. So that is one point which is going against the FAST, though most of the involvement, most common artery involved is the middle cerebral artery. The early recognition and early treatment is much better when you consider the FAST campaign. One another very important pre-hospital score, what they normally use is a Cincinnati pre-hospital score, which also has three parameters mainly, which is a facial droop, the arm drift, and the abnormal speech. Again, as you see in the diagram, you can very well see the facial droop. Basically, there is an angle of mouth deviation, and there's an arm drift. Very specifically, you see which arm is abnormal, and then abnormal speech. That is where you have to make the patient say, you can't teach an old dog new tricks. So normally the patient will be able to say these sentences without any slurring. But if the patient has a slurred word, so that means there's a possibility of stroke, and the probability of stroke interpretation is almost more than 70% when the Cincinnati pre-hospital score is positive. So that's what the next pre-hospital stroke scale is denoting. And so now we have done the pre-hospital scoring. Now what they do is basically the patient has been shifted to the ED without wasting time on identifying what type of stroke this patient is having. There is at least a minimum investigation which has to be done from the ED point of view. One of the most important differential diagnoses the patient may have is possibility of hypoglycemia. So it is very important to check the bedside blood glucose level prior obtaining the rapid imaging of the patient. So one of the most important, as we had pre-hospital scores, we are actually having scores which is helping us to recognize stroke in the emergency department, just like the Rosier scoring system. We will quickly go into the Rosier score. That is, Rosier means it is a recognition of stroke in the emergency department. We have, how do you classify the symptomatology? The points is you have clinical history scores, and then you have the neuroscience score. Clinical history is basically gives you a score of -1, and the neurological science give you a score of +1. So any score more than 1, the likelihood of stroke is almost more than 90%, right? And if the score is negative, it could be mostly a stroke mimic. So let's see what are the scores, what are the points which we have to consider. One of the most important thing is clinical history. If the patient has either loss of consciousness or probably an episode of convulsive fit, the score which should be given is -1 each. And regarding neuroscience, if the patient either has facial weakness, arm weakness, leg weakness, speech disturbances in the form of slurring of speech, or even a visual field defect, each symptom has to be given a score of +1. As I told earlier, a score of 1 or more makes a stroke more likely, and high positive prediction valuation as well as negative prediction value is also there. Again, so that leads us to the point that what are the stroke mimics? again, not every patient with weakness of the limb or slurring of speech or arm weakness or leg weakness can be stroke. So we should be knowing what are the possible stroke mimics. So let's see what are the stroke mimics. One of the very most important diagnoses is migraine, which is very common, especially in younger age group. So how do we have to differentiate is one of the most important parameters. So the symptomatology is the patient may be having association of aura with a sort of uh, um, uh, headache or probably loss of neurological function. And one thing which is very important is headache is not a feature of ischemic stroke, but is often associated with intracerebral hemorrhage. That should be always taken into consideration. The second diagnosis is possibly hypoglycemia, which you have already discussed. Third is seizure. Now, seizure again can be a complication of acute stroke, or probably can develop in some patient with acute stroke, possibly because of scar epilepsy or something like a epilepsy or a seizure potential is more in people who have already developed stroke. The fourth differential diagnosis of stroke mimic is a brain tumor. But what you should remember is the symptomatology or probably the history will be more gradual in onset rather than acute in onset, which is predominantly in the stroke. The fifth one is sepsis. Again, severe sepsis is associated with systemic hypoperfusion, which can develop into neurological dysfunction also. Again, the onset of time is mostly prolonged, not acute in onset. The next differential diagnosis is syncope. The next is toxic metabolites in the form of hyperglycemia, hyponatremia. Even hypernatremia actually can present like this. The most common one which we normally see is cranial 7 palsy, in which if the patient presents the element palsy, which is a lower motor neuron lesion, the whole one side of the face is weak, whereas upper motor neuron lesion, which comes as a part of stroke, will have only the lower third of the face is weak. So it is very important to differentiate a patient coming with facial nerve palsy. Is it upper motor neuron or lower motor neuron? So these are some of the stroke mimics which we should know. The list is not complete, but at least the most common causes has been sorted out. Coming to the investigation wise, the most important and the most readily available imaging technique is non-contrast CT. The main indication is basically to rule out a IC bleed or an intracranial bleed. Okay, the most important finding when you talk about a CT brain plane is loss of differentiation of gray and white matter interface. And another important thing is you have to rule out, as I told earlier, an IC bleed or subdural hemorrhage or even a brain tumor. So there are certain guidelines, especially NICE guidelines, which actually tells us when a patient brain imaging should be performed immediately for people with acute stroke if any of the following apply. One, if there is an indication for thrombolysis or early anticoagulation treatment, or patient is already on anticoagulant treatment to rule out any bleed, or a known bleeding tendency patient, depressed level of consciousness, that is GCS less than 13, unexplained progressive or fluctuating symptoms, papilledema, any signs of neck stiffness or fever, severe headache at the onset of stroke symptoms. So these are the set of symptoms by which we should know that patient should be going ahead with imaging, especially CT brain, non-contrast CT brain plane in the ED. So what does immediately means? Immediately means if the imaging is already happening in the CT suite, you make sure the patient which is there in the emergency should be taken the next slot or within the first 1 hour time of presentation in the ED. Okay. So these are some of the symptoms which we should always remember. Now, as I told earlier, there are some certain signs of stroke in the CT. One, the most important thing is loss of gray matter, white matter differentiation. And the other sign is basically we have something called as the MCA sign or the loss of insular ribbon sign, which is what which has been shown in the diagram. You can very well see on the right side, you can see the insular ribbon, which is basically the presentation of the gyri and the sulci. In the left side, you very well can see the loss of gyri or sulci, which we cannot see clearly. So that is what is called as loss of insular ribbon. The second thing is a hyperdense MCA sign, which refers to appearance of the middle cerebral artery and the CT. So the diagram which is on the left side is showing that hyperdense MCA sign. So that means there is increased attenuation of the proximal portion of the MCA, which is associated with thrombus in the first segment of MCA. And it's one of the early signs of MCA infarct. And this sign is typically seen within 90 minutes of the ischemic event. And it is very important to recognize this sign. And the most important thing is, even though it is very important to realize that this patient might be having a M1 segment stroke, this patient can only, or this sign can actually have only 30% specificity. And another important sign is insular ribbon sign, which we have already discussed. One of the diagram, the left side diagram is showing the hyperdense MCA sign, and the left side, the right side diagram is showing the insular ribbon sign. Again, there are certain benchmarks, which is we have to remember these benchmarks, which is very commonly asked in the exams. According to the NICE guidelines, the door to physician time, that means the presentation of the patient from the door to the physician seeing the patient should be 10 minutes. It should be ideally less than 10 minutes. Door to the stroke team will be maximum of 50 minutes. And door to the CT initiation is 25 minutes. Door to CT interpretation is 45 minutes. Door to drug, that means the thrombolytic drug to be administered is 60 minutes. And door to the stroke unit admission should be 3 hours maximum. So this is the time zone which we have to maintain when a patient presents with acute stroke in the emergency department. Again, so we have finished a lot of subsections regarding stroke, which we are coming as a reperfusion therapy. So what we are following is the AHA or the ASA guidelines. If we are thrombolizing the patient, it should be done within that 4.5 hours of onset of ischemic stroke. The drug of administration, which has been recommended, is alteplase. And definitely pre-thrombolysis, post-thrombolysis, we have a lot of protocols which has to be kept in place and remembered while thrombolizing, and we have to definitely take consent and explain all the possible complications of thrombolysis, and without thrombolysis what can be done should be also be explained. Now, as I told earlier, I'm just quoting some studies, which is the guidelines which has to be followed for reperfusion therapy. One of the most important studies which has been followed is a NINS Institute. Basically, it's a National Institute of Neurological Disorders and Stroke. So what they have done is basically they have conducted a study of huge number of patients to say that how much is the stroke recovery after giving the tissue plasminogen activated. And they have some sort of measurements which has been done, including the Barthel index, the modified Rankin scale, and the Glasgow-Coma scale, and the NHS. And what they can see is at the end of 3 months, there's a 12% absolute difference in modified Rankin score in patients treated with TPA by 3 hours. So this is a very important finding which has been given by the NINS trial. Another very important trial is the ECAS, or the European Cooperative Acute Stroke Study, which has been done. Basically, again, the patients are being randomized to treatment with TPA or placebo within 6 hours of onset of symptoms. Again, it has showed a 6% absolute improvement in the modified Rankin scale, but at the cost of increase in mortality with TPA and increase in intracranial hemorrhage. So what we can understand is, even though there is an improvement in the modified Rankin scale, there is an increase in mortality because a possibility of complications is happening because of TPA administration. Again, we have ECAS-2 and ECAS-3. ECAS-2 showing no statistical difference in modified Rankin score or mortality. Again, we can see a lot of patients present with intracranial hemorrhage post thrombolysis. And ECAS-3 is showing actually more patients with favorable outcome with alteplase, with no significant mortality difference and symptomatic intracranial hemorrhage. So the bottom line is we should know what are the patients who are the patients which we can thrombolyze. One, the clinical signs and symptoms consistent with acute stroke. There is a clear time of onset. The presentation is within 4.5 hours of onset. There are absolutely no contraindications, and there is a risk-benefit assessment favoring thrombolysis. As we told, what are the drugs to be used? Alteplase, that is 0.9 mg per kg body weight. The first 10% should be given as bolus, and the rest to be given over a period of 60 minutes. Again, so when you talk about a procedure, it has its own indication and contraindication. So I have divided this contraindication for ease remembrance as imaging-related contraindication, history-related contraindication, and there are investigation-related contraindication, examination-wise contraindication also. So imaging-wise contraindication, it's very common sense to say that if the patient has intracranial hemorrhage, you won't do. If there is a massive infarct, that means more than 1/3 of middle cerebral artery is involved. There's an extensive small vessel disease. That is imaging-wise. History-wise, the patient has not presented within 4.5 hours of onset of time, or the time of onset is unknown. Second is the patient is receiving effective oral anticoagulant treatment, seizure at the stroke onset, or history of stroke or head injury in the last 3 months, history of any previous stroke and concomitant diabetes, history of any previous intracranial hemorrhage, history consistent with subarachnoid hemorrhage even though CT is normal, any major surgery or significant trauma in the last 3 months, previous history of CNS damage in the form of spinal or intracranial surgery or neoplasm or aneurysm, history of a GI hemorrhage or a urinary tract hemorrhage in the last 3 weeks, or ulcerative GI disease in the last 3 months, recent history of arterial puncture at a non-compressible site, that means either subclavian or jugular vein, less than 10 days, history of a traumatic external heart massage or obstetric delivery, that is less than 10 days, recent lumbar puncture, heparin treatment within the last 48 hours, any history of severe liver disease, acute pancreatitis, neoplasm with increased bleeding risk, any significant bleeding disorder recently diagnosed or within the last 6 months, or non-hemorrhagic diastasis. Investigation wise, any platelet count less than 1 lakh or INR more than 1.7, or elevated thromboplastin time, or blood glucose less than 550 or more than 400. Examination wise, symptoms rapidly improving, or a low NIHS score, or a very high NIHS score, more than 25. Very important, systolic BP more than 185 mm mercury consistently, or the diastolic BP of more than 110 consistently. So these are the contraindications which we should remember before giving alteplase. Again, the Royal College of Physicians have recommended that patients taking NOAC or novel oral anticoagulants should be excluded from receiving alteplase. The only exception is patients on dabigatran, in which the RCP suggested if PT and APTT are normal, thrombolysis can be considered. But though it is not a straight indication, you should always discuss the local clinical lead. And reversal agents like adalimumab and adnexate alpha to be given, then administered alteplase. Other treatment which can be done is, again, if you see the studies, aspirin should be withheld for 24 hours in patient treated with a TPA. It should be given as soon as the hemorrhage has been excluded. It's a post-CT scan. And it can be given orally only if the patient swallows unaffected, or else should be given to the enteral tube or the rectally. And if the patient has a previous history of dyspepsia or aspirin, on aspirin, a PPI should be co-administered. And if the patient is allergic to or intolerant to aspirin, then an alternative antiplatelet agent in the form of clopidogrel should be given. Again, anticoagulation studies what has been done has proven that there is absolutely no benefit from any currently available anticoagulant in acute ischemic stroke, which include unfractionated heparin, low molecular weight heparin, heparinoids, or even oral anticoagulants and thrombin inhibitors. Very important to know about endovascular therapy, that is patients with the proximal intracranial vessel occlusion, which is actually causing a disabling neurological deficit. That means a patient presenting with an NHS score of 6 or more. If the procedure can begin within 5 hours of onset, that means the catheter should be ready to take up the patient, it can be done. Now, regarding the patient presenting with posterior circulation stroke, treatment up to 24 hours may be appropriate. So these proximal vessel occlusions, which means either intracranial or even extracranial, that means ICA or M1 or M2 segment of middle cerebral artery or even basal artery stroke can be taken up for endovascular therapy. So towards the end of presentation, we have specific stroke syndromes, which is predominantly has to be considered when the patient presents in the ER, are one of the most common and deadly stroke syndromes, which is called malignant middle cerebral artery infarct. That means a large space occupying middle cerebral artery or a hemispheric ischemic brain infarcts are associated with the development of massive brain edema, which can lead on to herniation and early death. Studies have proven there is a chance of 80% mortality due to herniation during the first week. And about 5% stroke can result in this complication, and almost all are caused by embolic occlusion of proximal MCA. And usually what you see is the patient may deteriorate from 3rd day onwards to the 5th day. And very important to know that young patients are particularly at risk because they have little cerebral atrophy. So any swelling may occur because there is limited brain space. So hemicranectomy can be the only procedure which can relieve the mechanical compression of the brain and which may improve cerebral perfusion. And studies says that it should be done within that 48 hours of stroke onset. So this is one of the stroke syndromes which will require an operative management, and that should be considered within the 48 hours of onset of stroke. Again, patients with middle cerebral artery infarction, which meet all the criteria, should be considered for decompressive hemicranectomy. That means a pre-stroke modified ranking score of less than 2, clinical deficits indicating infarction to the MC territory NHS score of more than 15, decrease in level of consciousness to a score of 1 or more, signs on CT, basically at least 50% of MCA is involved, with or without additional infarction in the territory of anterior posterior cerebral artery on the same side, or infarct volume greater than 145 cubic centimeters on DW MRI scans. Patient should be referred to neurosurgery within 24 hours of stroke onset and treated within 48 hours of stroke onset. There is a trial called Destiny 2 trial, in which a previous upper age limit of 60 was withdrawn. And it is recommended that decision to take up major life-saving surgery should be considered on individual basis. And there is no strict criteria of age to be excluded regarding surgical treatment of stroke. Decompressive hemicranectomy can be a life-saving measure in malignant MCA stroke. The second specific stroke syndrome is basal artery stroke. Now, this is a very rare condition, but the patient can have high mortality and morbidity rate. The problem is the basal artery is formed by the union of two subvertebral arteries, and it terminates to form the posterior cerebral artery. So, the patient may have symptoms of posterior circulation stroke following the or preceding the same thing, basal artery stroke. So basal artery occlusion basically can present with history of severe quadriplegia, coma, and locked-in syndrome. And patient may have a course of posterior circulation symptoms, which become progressively disabling. And the most important motor manifestation is asymmetric quadriparesis. Now, these patients can actually have bulbar symptoms also because of, as I told earlier, post-circulation stroke, which can result in facial weakness, jaw weakness, dysarthria, dysphonia, dysphagia, and even eye signs. Basically, oculomotor and pupillary functions dysfunction can present, especially in distal basilar stroke, which is caused by emboli. Again, the most important imaging modality is CT angiography, and patient presented to the ED with a reduced level of consciousness are likely to be investigated as CT, and CT angio should be done at the earliest. Two options are there, again, either intravenous or intra-arterial thrombolysis or even mechanical thrombectomy may be beneficial, presenting to the patients, which comes in the golden hour period. The most deadliest and the missed one under the diagnosis is carotid artery dissection. It is very important cause of stroke to consider in patients younger than 50 years. One of the most important parameters is males are mostly involved, especially under the age of 45, and it has a mortality of up to 5%. And the most important clinical symptomatology is there could be a history of head or neck trauma, including a manipulation by the chiropractor or the massager, which could be a possibility of precipitating factor. Aneurysm, hypertension, atherosclerosis are also associated with carotid artery dissection. And dissection should be considered in patients with ischemic stroke. But what you should know is the usual cardiovascular risk factors may not be there. So presentation may be, it could be asymptomatic or maybe a face or a neck pain, ipsilateral headache, asymptomatic to a certain level that patient may not even have a prior history of any CVA, or may patient present with Horner syndrome as well. As I told in the presentation, it is mostly the patient may have only neck pain, and it could be very sudden, very severe, and it is persistent. Again, we have to either go for a MR angio or a CT angio to get the diagnosis. And the most important thing is, as a Cochrane review is saying, no difference in efficacy of antiplatelet and anticoagulant drugs at preventing stroke and death in patients with symptomatic carotid and vertebral dissection, because the treatment entirely is quite different. So, as you all told, the treatment for this condition is basically, we have to know is it a dissection or not, and we can only give some sort of the resolution of symptoms. As you all know, it's actually having a good prognosis. So there is no treatment approach which we can do from the ER side, which probably we can admit under neurology or neurosurgery to further evaluation. What we can do is basically to control the BP and other factors, thrombolysis, which may not be done in this kind of because it's a contraindication. So that concludes the presentation about stroke. So what we have covered in this presentation is the etiology, what are the types of stroke, what are the pre-hospital scores, what are the ED score lines, what has to be considered when the patient is stroke, the drug administration, the indication, the contraindication, the stroke mimics, what are the indications for surgical management in stroke. And then we came to the last session of the presentation, which is specific stroke syndromes, which is including the basal artery stroke, the malignant MCA syndrome, and finally the carotid artery dissection. Thank you for your patient listening. Hope to see you all again in further videos. Thank you all once again, and good night.